Good afternoon, everyone. It's a pleasure for me to come on this Docplexus platform and share my perspective on tuberculosis. Tuberculosis, on the eve of this World Tuberculosis Day, tuberculosis is a major public health problem in India and a leading communicable disease problem. Daily, we lose in our country only about 1,400 people from tuberculosis. And there have been many government interventions. The first program started somewhere in 1960s with District Tuberculosis Control Program, which was based on the case finding, passive case finding, and treatment. Subsequently, we had DOTS in 1997, which was a major boost, which was directly observed treatment short term. And subsequently, now the agenda is end tuberculosis. The WHO and SDG goals are end tuberculosis by 2030. Indian government is more ambitious. It has given a call for ending tuberculosis by 2025. So today we'll be reviewing what is the progress towards this, what are the challenges and what are the opportunities and how we go forward. So this would be the scope of the session. What is the TB burden in the world and India? What has been the government responses and what impact and challenges and setback to TB elimination, such as social factors, poverty and malnutrition, living standards, COVID-19 pandemic, Ukraine war, and development of drug resistance, multi-drug resistance, and extreme drug resistance tuberculosis, and what are the opportunities and the way forward. So this is India has a major share of the global burden. It has almost a quarter of the TB cases in the world are in India, and two-thirds of the cases are in Asia and African countries. So TB is a leading cause of mortality from communicable disease worldwide. Over 10 million new cases occur globally with almost 1.6 million deaths. India has a disproportionate higher share of the global burden. In 2021, almost 21.4 lakh cases were notified in India. And daily, as I had said earlier, 1,400 people we lose to tuberculosis daily since many years, 4 to 5 lakhs we are losing from tuberculosis, young people in their productive years. And just to give you a perspective, in the peak of COVID, there were about 1,000 plus deaths in the second wave. But year after year, we are losing 1,400 people. Earlier, we are losing more than 2,000 people. With some success, we are losing 1,400 people. So that will give you an idea that in spite of a proper treatment, in spite of a vaccine, this is a burden which is much higher than other communicable diseases. So what has been the government response? Earlier, of course, there was no, even drugs also. So most of the treatment was by sanatorium. The TB patients were kept in sanatoriums and with good nutrition food. Some of them improved, some of them died. In fact, TB is associated with overcrowding and poor standard of living. And most of the developed countries had controlled TB before the antibiotics and before the vaccine by just improved standards of living. So that is a major determinant which we require. As a country develops, the TB burden falls down. Then, as I said, we had the district TB control program in the 1960s, which was based on passive surveillance and domiciliary treatment. Then the direct observed treatment short course to improve the patient compliance started in 1997, and it was renamed as Revised National Tuberculosis Control Program. Microscopy centers were set up, DOTS centers were set up. Anybody could be a DOTS provider like community health worker, ASA, volunteers, that the TB drugs were given under supervision because it required some long-term treatment and patient compliance was a challenge, short-term challenge, because just after a couple of months of treatment, patient becomes asymptomatic. and the treatment has to continue for more than 6 months. Earlier, it was more than 12 months. So the patient tended to drop out of treatment because he or she used to feel well. So for that, the directly observed treatment, that under supervision, the treatment administering the drugs, that improved the impact. And then early diagnosis and treatment and community involvement. This was a part of the RNTCP by microscopy centers, sputum examination, and community involvement like ASA workers and other volunteers. Then, despite significant progress, the Sustainable Development Goal target of TB will not be achieved, because to achieve the end TB by 2030 or even by 2025, which is more ambitious, the fall in tuberculosis incidence has to be more than 10%, which has to be sustained. Every year, the incidence should, from the previous year, should come down more than 10%. As on today, decline is only 1 to 2% each year. So it is, we are falling behind target. We are falling. We are not going to meet the target. So this is, one has to be pragmatic, and we have to, because there are certain reasons. What were the challenges which came? These are the challenges which is making the target difficult to achieve. Social factors like poverty, malnutrition, stigma, and living conditions. Poverty, and particularly after the pandemic, many people have lost their jobs. Many businesses have been shut down. So poverty, many people might have gone down the poverty scale. This malnutrition can also be a challenge which predisposes people to have tuberculosis. In fact, in endemic countries like India, a large proportion of the population are carrying the tuberculosis in their body, the tuberculosis agent. It is firstly in childhood they get the primary complex, and then they have some dormant foci for many years. And when the malnutrition comes or immunity goes down or some other infections like HIV comes, there, or diabetes, or old age, the TB can flare up again. So it is not only the bacteria or the agent of tuberculosis which causes tuberculosis. More important are the host factors. As I said, many countries with improved socioeconomic conditions and living and good ventilation and good nutrition, they control TB before the antibiotics or before the vaccine. Then, as I said, the COVID-19 pandemic, during the pandemic, about 20 to 40% detection went down. TB detection went down by 20%, and some years or some months it went down by 40%. So this has increased the reservoir of infection. So this will also infect other people. And many people might have dropped out of treatment because during the pandemic, many of the services were closed, and many of the resources for TB detection and TB control were diverted for COVID control. So this was a setback. Then the stigma, even now, we have done studies in our community. Even now, the stigma of tuberculosis is there. And because of stigma, people do not come forth for treatment. And if they don't come forth for treatment, they spread it to others. So stigma is a major challenge which we have to overcome. Then the health system challenges. This is again a pressing problem in our country, that we do not have equitable health distribution, health services distribution, the primary health centers, sub-centers, adequate staff at the peripheral level. So healthcare workers, DOTS workers, sputum microscopy, or diagnostic services. So these also have to be beefed up to meet the challenges. Adherence issues are there. Compliance, that, as I said, patients feel better after a couple of months, so they drop out of treatment. Besides that, most of the poor people are nomadic. They will work for some place and then they will go to some other place to work, and they are the migrant population. So they may be lost to follow up. So these are some of the logistic problems. Then diagnostic challenges, again because of our health system challenges, because diagnostic services have to be in the periphery, have to be in the deprived area. Most of the diagnostic facilities will be in the areas which are economically sound, but tuberculosis occurs in the tribal area or marginalized population where the diagnostic services may not penetrate. And then, of course, we have got a difficult to eliminate is because whenever there is an extra human reservoir, there is always a reservoir which is difficult to eliminate and which can always give a pool of the bacteria for subsequent infections. And animal like bovine tuberculosis is common in our country among cattle. And we are a country where large number of people, particularly the marginalized people, depend on animal husbandry for their living. They are working close with the animal. So this also can pose a challenge for elimination, which we have to keep in mind subsequently. Of course, I had recently a discussion with an expert. He says ki from animal to man transmission is less common than from humans to animals, but still it is there. So that can be also a barrier to a challenge or a barrier to elimination. Yeah, these are some of the challenges I have shown it graphically. So these are one is the socioeconomic determinants, poverty, then health system challenges, and drug resistance also occurs. That almost 10%, 5 to 10%, sometimes 15% of the new TB cases may be resistant to the first line TB drugs, and the second line drugs become very costly. And then stigma associated with tuberculosis, adherence problem, diagnostic challenges. To this, we can add that we are having also a high burden of HIV. HIV, tuberculosis, co-infection is very common. And as I said, immunity goes down in HIV and the TB also surfaces. So they are combined. We have to treat against tuberculosis as well as HIV. Another problem is that we are becoming or perhaps we have already become the diabetes capital of the world. And diabetics also have a reactivation of the tuberculosis foci. So these are again the diabetes control. Obesity is increasing in our country. Obesity and diabetes. Obesity predisposes to diabetes. So that is, and the fast food and overnutrition. On one hand, the poor people are susceptible to tuberculosis because of undernutrition, and on the other hand, the affluent are susceptible to tuberculosis because of obesity and resulting in diabetes and impaired glucose tolerance, which can predispose to tuberculosis. So, what are the opportunities and the way forward? There have been some recent technological advances and also program management advances which gives us opportunities, and the way forward towards TB elimination may not be, it may be really unrealistic to say that we can eliminate it by 2020. But of course, in the near future, say a decade or two, we will bring it down to levels which should be not pose a public health problem. We cannot eradicate it. Elimination is bringing it down to a lower level, which is much manageable, and where the people do not get impoverished due to tuberculosis. So what are the strategies, opportunities? We have got this National Tuberculosis Elimination Program, which is focused on early case detection. Like we have got better diagnostics. Earlier we had sputum. Now we have got gene expert and other diagnostics, molecular diagnostics, and which, if it can penetrate, can detect more cases and treat them so that the spread, the chain of transmission is reduced a little. It doesn't spread more and more new cases do not occur. Standardized treatment regimes, this will involve another weak spot was the most of the 50% of our people are seeking treatment from private practitioners. So this new strategy involves the private practitioners. More numbers of private practitioners, even traditional practitioners from other systems of medicine are being included in the training and in the orientation to give standardized treatment. Then increase the drug sensitivity test to all patients, because as I said, multi-drug resistant tuberculosis is posing a major problem. So if we initially only to all patients, we identify that whether that patient is resistant to first line drugs, we can start on the second line drugs and cut down the infection reservoir. Shorter, more effective treatment for multi-drug resistance and better compliance. So there are developments in drug development. And digital technologies like telemedicine and mobile phone used to improve diagnosis and follow-up compliance. As I said, most of people like migrants, nomadic people, laborers, everybody mostly has got a mobile connection nowadays. So with their platform, digital platform, they can be followed up. Reminders can be sent to them if they just lapse and do not collect their medicine. So this will reduce the dropouts from treatment, which is a major cause of development of drug resistance and spread of infection in the community. And other continued opportunities and the way forward, involvement of private practitioners, as I said, engage and regulate the private healthcare providers for ensuring standard treatment. This is very important. The government can give them the anti-tuberculosis drugs, which they can, or they can refer the patients diagnosed with tuberculosis to government treatment centers for compliance and adequate management of the cases. And the standardized treatment can be given. Importance of malnutrition, integration of nutritional support into TB care. Like malnutrition is one of the major cause of reduce in immunity, and the TB lying dormant gets activated. So, and even for recovery with the drugs, anti-tubercular drugs, nutrition is required. Extra nutrition is required by a recovering patient to gain weight. And now government is encouraging volunteers or from the community to take support a patient of tuberculosis by giving them nutrition. Mitra, TB Mitra or associations are being formed, or corporate responsibilities are also getting interested in caring and improving the nutrition of tuberculosis patient, besides volunteers from the community who give nutrition to adopt a TB patient to give the nutrition. Involving communities in awareness program, case finding and reducing stigma. Reducing stigma is very important, and awareness and case finding. So progress towards elimination, the technological advances, intensified efforts on molecular diagnostic like gene expert, and significant increase in detection of multi-drug resistant tuberculosis. A gradual, very modest decline has resulted in TB incidence. For the past few years, we are having a modest decrease in incidence, but as I said, about 1 to 2%. Or required rate is 10%. So we are much behind the target. So we have to scale it up. Research ongoing for newer drugs for multi-drug resistance and extremely drug-resistant tuberculosis. Newer vaccines, there are certain vaccine candidates for which the trials are going on, and as you know, the previous vaccine has been a failure. I mean, not very encouraging. The BCG vaccine was given at birth and it is still given at birth, but in India, the BCG vaccine's performance has not been very good. But they are working on other vaccines. And BCG trial in adults has been contemplated. We'll just discuss it later. And as I said, past history, like we gave BCG to adults was stopped. In fact, in the 1970s, I remember I was in the armed forces. We used to give BCG vaccine on entry to the armed forces to new recruits and new soldiers, which was discontinued after we found that there is no effect of BCG vaccine. But again, the trial is being started on some vulnerable population. We'll see. So let us see. We have to keep our fingers crossed whether it helps or not. Past experience has not been very good, but as I said, newer vaccines are on the pipeline, and perhaps with new technology, perhaps we may have a better vaccine. Role of NGO and civil society, as I said, for nutritional support and for removing stigma, and leverage of a digital technology like mobile connectivity and on the platform, and digital and in artificial intelligence also can be used in the future, AI and telemedicine, to reach out, because after the initial diagnosis, the challenge is the treatment compliance for 6 months or depending on the minimum 6 months. So if we, once the diagnosis is made, the telemedicine and digital platform can be used to reach out to the patients and remind them of their treatment. The dots can be on the digital platform also. You can have a person taking dots on a camera, and to the dots provider can be at a distance if there are problems of accessibility. These can be. And these are what are the strategies and recommendations. Future research and development have to be scaled up in newer drugs, newer vaccine, new digital platform, integrated healthcare systems. Like as I said, our healthcare systems in the periphery suffers from inequity, particularly remote areas, tribal areas, rural areas, hill areas. So, and the tuberculosis treatment and diagnostics have to be integrated in the general health services, right from the subcenter or primary health center, and integrate it with the delivery so the patient doesn't have to travel more. Digital health technologies and international collaboration, of course. Like internationally, also there are setbacks. If there is a, like COVID was a major setback in the TB, similarly, the Ukraine war is a major setback in the tuberculosis control globally. Ukraine is a highly endemic for tuberculosis, and so is Russia. And the two countries are in war, and there are refugees from Ukraine to large number of refugees, and the refugee camps are overcrowded, poor ventilation. Then refugee camps, there is poor nutrition, so there can be flare up of tuberculosis in the refugee camps. And since they move widely to other places, other countries, they will be carrying the infection. So, and now with the global travel, anything in one part of the world can spread to other part of the world. So international collaboration is very important, and any setback at one region of the world globe can be a setback for the other region. So COVID was a universal pandemic. Ukraine and Russia is again a disaster, which is a major setback. Similarly, there are in our country, there are Maoist area, then there are disturbances in certain states like Northeast or JNK. So these can also pose a barrier. And advocacy and policy reforms. Advocacy for support to TB patients, advocacy for more funds. In fact, recently the government of India has increased the funding for tuberculosis control. So that's a good thing. It has increased it, I think, 3 to 4 times. And policy reforms. So what is the actual targets? That is the end TB target for 2030. The target is very ambitious. There 80% reduction in TB incidence from 200 lakh per lakh, more than 200, around 200 per lakh to 43 per lakh population. If the population, for every 1 lakh population, more than 200 people get tuberculosis in a year. So that incidence has to come down to 43 per lakh population. That is 80% reduction. That means for 8 years, if you take, now we are already in 2024. So even if we have a 10% reduction every year, then it will take 8 years to bring it down to that. And as I said, for the past 3 4 years, the reduction is only, instead of 10%, it is 1 to 2% only. So we are not going on course. Then 90% reduction in TB mortality from 32 per lakh to 3 per lakh. So this also we have to work hard, because once we are not getting the incidence down as we desire, so it will be difficult to get down the mortality. Then 0% patients having catastrophic expenditure due to tuberculosis. Because poverty leads to tuberculosis, and tuberculosis again leads to poverty. And they get catastrophic expenditure, out-of-pocket expenditure. So for that, involvement of the private practitioners, they have to be supplied with anti-TB drugs, so patient doesn't have to pay from the pocket. And new interventions to decline TB more than 10%, 10 to 15% annually by detect TB, molecular diagnostics, new methods, encourage people with cough, fever, any symptom, or also their household members to come forth for screening. And they are also now also introduce the prophylaxis isoniazid to the contacts, household contacts, so that the infection doesn't spread. And build approach. So this is the approach. So we are off track as on today. So as I said, BCG vaccination trials are being envisaged in 23 states. So some districts will be used to give this BCG to adults, not all adults. It is adults above 50 years who are with prior TB disease, and underweight adults who are the risk, diabetics and smokers and alcoholics, maybe HIV patients also. That, as I said, 33% of Indians may be carrying harboring the TB bacillus, but they do not suffer because of good host nutrition, good host immunity. But those who are underweight, diabetic, smokers, they are more likely to get TB. So the BCG revaccination trials they are contemplating in this target group in some districts of India. So I think these are some of the references I have put. This from the facts and figures I have taken. So these are all the references. I think I have finished. So I can come out of a slide set. So I can take any questions if you have. I can.
Sure, sir. We'll move on to the first question now. So my first question to you is, in your opinion, what is your top suggestion to strengthen and ensure effective and equitable delivery of TB service?
So good question. Actually, it's a basic question of equitable distribution of our health services. We are having a major problem right from the high to the grassroots workers, from doctors to the grassroots healthcare workers. Most of our resources are in the urban areas. 60% or 70, I would say 80% of our resources are in urban areas, and where all actually 60 or 70% of our people are staying in rural areas. So we have to have health services right up to the sub center or primary health center, and now they have got under the Ayushman Bharat, they have got the wellness centers where they have trained community health workers. I think they can use these people can be used to help us eliminate tuberculosis, because they are there to generate awareness, and they can also monitor the delivery of the tuberculosis services. So I think this is one way. Under the Ayushman Bharat, the wellness centers, most of the primary health centers, they have been boosted by these community health workers or community health officers who this is an extra human resource which can help in elimination of tuberculosis.
Thank you, sir. Moving on to the next question. So my next question to you is, how can we raise awareness and reduce stigma surrounding tuberculosis in India, particularly among high-risk population?
This is this is an important barrier. Stigma is an important barrier, and particularly not only stigma with tuberculosis, the stigma also depends on the gender. If a woman gets tuberculosis, she feels more stigmatized than the male member, and they tend to avoid coming for diagnosis or treatment. So stigma is a major issue, and this is has to be. Stigma is a social pathology, and we require social scientists to develop the health education modules right from school level, community level, or even by street plays. Now we have got the social media, so where the success rate of tuberculosis treatment can be emphasized so that people know that in because stigma comes out catching TB from the other person. So once we convince humanity and the common person that once the person is put on treatment, he or she is not infectious to others, and even if a person gets TB, he or she can get cured very well. And so stigma will gradually disappear by the providing the services and providing the results, so, and being transparent and informing about the success of treatment. I think that is the only way forward.
Thank you for that answer. Moving on to the next question. My next question to you is, what lessons can be learned from successful TB control programs in other countries that could be applied in Indian context?
As I said, in other countries, the sustained success has been due to improved standards of living, like better nutrition. Main is nutrition, better accommodation, better working and living conditions. So here is a yeah, that we require a holistic approach to improve the general health of the people. Number one. Number two, as I said, malnutrition is one end of the spectrum of immunity. Malnutrition gives you poor immunity and you're susceptible to tuberculosis. The other end of the spectrum is people are becoming more obese, affluent class, more sedentary, and they are getting more, they are having higher risk of diabetes or glucose intolerance. So this diabetes also predisposes to tuberculosis. So it is this sustained message has to be that ideal nutrition and neither overweight, neither underweight. And the ideal nutrition can be by prevent overweight is by then another menace which is now common right from school in affluent regions are the high sugar consumption from childhood, cakes, pastries, drinks. This leads to obesity and diabetes in the long run, which again can increase the tuberculosis burden. So this also has to be taken care of, and healthy food and ultra processed food. So all these things are interrelated. Nothing can be taken in isolation. So if you have good overall health, and of course access to treatment and diagnostics. So tuberculosis can affect anyone, even the well-to-do class. So early access to diagnosis and treatment. So this is the way forward.
Thank you, sir. And towards the last question, if you can sum up this session in 1 minute.
Yeah, thank you. As we have seen, the tuberculosis is a major problem since antiquity, and in our country we have been trying to cope with tuberculosis since independence, one can say, or before independence. So many interventions had been done in the 60s. We had even the mass radiography, also mass miniature radiography, that was found that we were overdiagnosing cases. Now we had the domiciliary treatment, which was under trial conditions, which was very effective, but it did not sustain, it did not have the desired patient dropout was there. Then to overcome this patient dropout, we had this directly observed treatment schedule, short term. That had some modest success. Then we are having now today then better diagnostics. And another advantage is earlier for culture and other things we had to wait for 6 months. Now we can get a definitive diagnosis faster, and we have having these diagnostic services at a larger scale. It has spread out, but still there are some challenges to be overcome. As I said, pandemics like the COVID, we subsequently, this can be a lesson that if whatever comes, we should not let our TB program get derailed. COVID derailed our TB program, whereas ultimately it was found that TB is a much serious disease than COVID, which are transient viral infections, and we are also worried about future pandemic. So our TB control should not be derailed. We are behind the schedule of elimination because we have to scale it up more than 10% reduction every year. As on today, we are having only 1 to 2% reduction. So by any stretch of imagination, 2020 deadline we will not meet. We will not meet the world deadline, also elimination of TB by 2030. But we can build up the tempo so that at least within a decade we may be able to meet. And in between, if there is some development like vaccine or some other year, but by and large, sustained control has to be by firstly improving the population health, control of undernutrition as well as overnutrition, obesity, and health services which are universally accessible. If the health services are accessible, TB can be very treatable. There will be no mortality, and the people will not go below the poverty line due to tuberculosis. Thank you.
Thank you so much for the session, sir. We